Um, so like I said before, this initial lecture, we have a lot of first year residents that are doing consults in the hospital and stuff. So we can't get into many of these topics in extensive detail. However, we do highlight major aspects of them in order to um, keep them up to date and see, how they need to work it up and therapeutic options and stuff like that. So, because pemphigus lecture in itself or immunobullous disorders in itself can last an hour. Especially with nuances and new details that come out every month. But again, the purpose of this initial series of lectures, also presented by Laszlo, I think he's got some ones that are relatively basic so that everyone catches up for the first years that are just starting their residency, which is their first month. So last week we ended with pemphigus vulgaris, and this week we'll start with pemphigus foliaceus and another immunobullous disorder, which is part of the pemphigus group and intraepidermal immunobullous disorders. The primary reactant, is an IgG autoantibody, and it's targeted to desmoglein 1. Okay, and this is a desmosomal antigen, which we'll talk about. It's 160 kilodaltons, and there's a huge desmoglein theory that I'm not going to get into here, but if you know it already, especially the second and third years, you know why this disease primarily affects skin and not mucosal areas. Again, it's a desmosomal transmembrane cadherin, which is calcium dependent protein. And you can see here, this is just the basement membrane zone. These are the basilar keratinocytes, and just hemidesmosomes connect the cell to the basement membrane zone to intermediate fibers, whereas desmosomes connect two cells together, okay, rather than to a matrix. Now, like I said, PF doesn't typically have mucosal involvement, and that's because of where the desmoglein 1 location is. These tend to be flaccid bulla, and they'll create this kind of crusted, scaly appearance, some of which this has been described as like a corn flaking or cornflake kind of appearance. Not infrequently, it will be generalized, but many times it will have a predominantly seborrheic distribution, and these not infrequently, especially when they involve the head and neck, which is not uncommon in pemphigus foliaceus that affects the face, they'll come in as, rule out squamous cell or rule out a connective tissue disorder, such as subacute cutaneous lupus erythematosus or even DLE, depending on the appearance and the chronicity of the lesion. You'll see here, this is a patient with erythrodermic variant of pemphigus foliaceus. And when we do admit, or we do see the patient as a consult, because we haven't, this is one of the reasons an erythrodermic patient with pemphigus foliaceus, for example, we can admit these patients, or if you get a consult, check their CBC, their fluid status, their renal function, and liver function, and not necessarily because the disease itself specifically targets anything, but rather that the secondary outcomes can compromise the skin barrier and the systemic stability. So we do look at the electrolytes, renal function, and liver function. Now, G6PD and TPMT, or even HIV, Hep C, Hep B antibodies, we do check, or even PPD for tuberculosis, we do check if you do consider using an immunosuppressant. And some immunosuppressants like dapsone, you need to check the G6PD, etc., so on and so forth. In mid-September, I think I'll be talking about azathioprine, and we'll go into this topic here. Now, pemphigus foliaceus, like pemphigus vulgaris, is an intraepidermal immunoblistering disorder. However, in contrast to pemphigus vulgaris, if you can see my arrow here, it is predominantly in the superficial layers of the epidermis, and you'll see loss of the stratum corneum. You may see some lower levels, but that's not the more common. This could be theoretically, pemphigus vulgaris, to be honest with you, because there is some suprabasilar involvement. However, with pemphigus foliaceus, you'll see this pattern where you'll see the acantholysis in the superficial epidermis with loss of the cornified layer. You don't typically see keratinocytic apoptosis, and the reason to say that is because there is a differential diagnosis, histologic. When you do see that, that could be either pemphigus erythematosus or even PMP if it doesn't have all the, if it has features of erythema multiforme. And eosinophilic spongiosis is not infrequently seen in all immunobullous disorders. So pretty much all of them. I mean, you don't see in bullous lupus, rarely in EBA, but the vast majority others, including BP, PF, PV, etc., we do see eosinophilic spongiosis, and you may not necessarily see acantholysis, and you may see that as a differential for a subacute spongiotic dermatitis with eosinophilic spongiosis. The differential is vast, but just understand that any of the immunobullous disorders may show that. Now, as far as the direct immunofluorescence is concerned, again, you'll see intercellular, okay, deposition that is linear, predominantly of IgG, okay, on occasions IgA, no IgM, but rarely you will see C3. I mean, you will see that on occasion. It's not, doesn't leave that out. Now, indirect immunofluorescence studies, when you put the patient's serum, and then we have a lecture, we've had lectures by myself and others on direct immunofluorescence, will determine whether, if you do it on human skin, you'll see if there are circulating autoantibodies with the pattern that will show that of, please mute your, if you could mute whoever just jumped on, thank you. The indirect immunofluorescence will allow us to understand better the specificity of where the target is and what's circulating. In human skin and guinea pig esophagus, this helps us distinguish this from, for example, BP or even PMP. Rat bladder is actually the big one for differentiating pemphigus family from PMP, but again, it's beyond the scope of this lecture. Indirect immunofluorescence is also associated with the activity of the disease and how drug therapy is going, and that's the same for pemphigus vulgaris as well as BP. Once admitted, supportive care, obviously if there's fluids that are needed, antibiotics for secondary infection. Clearly, if you feel that there's infection, cultures are also warranted. Wound care, non-stick sheets. You can try super potent topical steroids. However, as many of you know, PF is pretty resistant, and we do end up using systemic steroids and steroid-sparing agents. Systemic steroids, once we admit them, IV steroids, we provide 1 mg per kg per day. And then again, this typically is a long-term disease, unless you really need to be conscientious of the steroid side effects. So you have to add a steroid-sparing agent. Most commonly used Cellcept, but there are all these that have been shown to be quite effective in pemphigus families and even BP. I'm going to talk about this because this was a paper published by in Wake Forest, and I kind of like it because I kind of follow this. It's basically, you guys can find it was published in 2011 in the JAD, March. Just kind of shows an algorithm of how to approach all pemphigus groups. They talk about pemphigus vulgaris. However, this actually works for BP as well as PV. A patient with active pemphigus vulgaris, you start them with 1 mg per gig. I'm sorry, 1 gram of mycophenolate mofetil twice daily, and prednisone 1 milligram per kilogram daily. You can increase to 0.5. I tend to just start, depending on, unless they're a very small person, I tend to start with 1.5 grams twice daily of Cellcept. You can maximize the dose at 3 grams, although I've seen more than that. And depending on what's going on, if you achieve remission and control, you're in good shape. For your prednisone, you'll probably be on mycophenolate mofetil for at least 2 or 3 years. maybe longer. If you can improve and 6 months have gone on, and patients not improving in max dosages, you really need to start considering either rituximab or IVIG. This was just the new patients that they looked at, very similar. Now, you do want to avoid many medications that have been associated with drug-induced forms of pemphigus. The big one is penicillamine. However, piroxicam and others have been associated. Here it is again, drug-induced PF. You'll see penicillamine is the first and number 1, captopril number 2, bucillamine's number 3. The H&E will be the same, and the direct immunofluorescence will also be the same as that you'll see in in idiopathic forms. Now, you also have positive indirect immunofluorescence as well as ELISA studies against desmoglein 1 in this case. Now, for BP, it's not an uncommon admission or consultation in older patients. Many patients over the 60, even 80, 90, as we know, they're admitted for many other reasons and may develop bullous pemphigoid or even flare. So this is a common consultation. Age greater than 60 years old, males more commonly than females. Mucosal involvement is not uncommonly seen. Same with cutaneous, obviously. Very pruritic. Check recent medications because they can trigger this, and recurrences can be seen. Now, not infrequently, they will present as urticarial lesions, so don't get burned by that. It's symmetrical, and look closely. See if there are blisters or even erosion secondary to loss of rooftops of blisters. These are the tense bulla that we typically see with bullous pemphigoid, because remember, this is not intraepidermal, but rather subepidermal. It occurs, the target is the hemidesmosomal proteins. So these tend to be tense bulla. Can occur pretty much anywhere. Erosions, crusting can be seen, and not infrequently we will see hemorrhagic bulla. Probably the number 1 and 2 differential with this is EBA or linear IgA bullous dermatosis. Third of patients may present with oral erosions. Again, we talked about this. The antigen target is BP antigen 1 and 2, which is BP antigen 180 and 230. You'll see the target is here, the hemidesmosome. Okay, so it's within the basement membrane zone and the basilar layer of keratinocytes. The workup, very similar to what we spoke about with pemphigus family, not necessarily for bullous pemphigoid in itself, but rather because of the cutaneous breakdown, you may have fluid losses, etc., and so on and so forth. Indirect immunofluorescence also can confirm your direct immunofluorescence findings, as well as give you an idea of the activity of the disease. ELISA studies can also be ordered. We do have ELISA. You just have to put, available in the clinic. We have it. You just on your forms. Typically, it's not a typical blood work form. Blood work checkoff. One of these listed ones. Just right in there, in your not in the path forms, but rather the blood work form, wherever the patient gets their blood work done. Just right in there, ELISA, and then you can put whatever antigen for the immunobullous disorder that you're searching out. The skin biopsy, although is important, it is not definitively diagnostic. There are patterns that we see. You'll see here, this is the pretty classic one, which is subepidermal cleft with polymorphous infiltrate with heavy eosinophils, with even eosinophilic spongiosis. Here you kind of see the eosinophils lining up along the dermal epidermal junction with small kind of clefting at that junction. Do a Zank smear. I've had this happen to me, patients with generalized herpes, older in the ICU, and I thought it was bullous pemphigoid. The biopsy will show herpes. However, you want to exclude that because you don't want to provide steroids without appropriate antiviral therapy. Herpes cultures, bacterial cultures, because it's not not infrequently they're super infected. Okay. We talked about this ELISA studies. The sensitivity is approximately 95%, specificity about 96%. The direct immunofluorescence depends here. It says C3 greater than IgG at basement membrane zone, and it's a linear. Okay. Two pattern, you know the pattern of linear versus granular. You locate where it's located within the biopsy specimen, and then what's the predominant immunoreagent. In this case, in a bullous lesion of bullous pemphigoid, the predominant immunoreagent is going to be complement 3. Okay. However, if you're in an urticarial phase, IgG will predominate. You won't have much C3 or you won't have any at all. So you can have an IgG positive linear basement membrane zone deposition with negative complement deposition. The predominant immunoglobulins are type 1 and 4. And the sensitivity, just depending on the literature that you find and read, it'll be anywhere between 40 and 90%. Indirect immunofluorescence studies can be done. Again, salt split human skin or monkey esophagus can be performed, show the similar feature along the basement membrane zone. IgG will be the predominant, sensitivity 60 to 80%. Not correlate with disease activity and cell form. It can give you some information. It's better for pemphigus. Now, as far as bullous pemphigoid is concerned, the treatment options, depending on the patient, it says topical or systemic. Many studies in the last couple of years have shown that high potency steroids like clobetasol can keep the limited disease under control, so mild to moderate disease. However, we tend in severe disease to go straight to systemic, whether that's by mouth or IV steroids. Again, in this disorder, depending on the severity, you need to consider the possibility of a steroid sparing agent. I haven't had much success with tetracyclines or nicotinamide, but there's a lot of data showing that these drugs do help in remission for this entity. This was just a paper in the New England in 2002 when I was a resident, just comparing oral and topical corticosteroids, just showing that in mild forms, topical steroids are fine if you can keep it under control. This pemphigus vulgaris algorithm that we talked about helps with pemphigoid as well in severe cases. Other options include IVIG, plasmapheresis, and photopheresis. For oral care, this is much like what we talked about for toxic epidermal necrolysis that we use in erythema multiforme. It's a magic mouthwash that we use that contains a steroid solution with nystatin, Maalox, and antihistamine, hydrogen peroxide and water 1:1, and viscous lidocaine for pain. Non-stick sheets we use is for inpatients that are admitted, and hydrocortisone topically. You do want to avoid sulfonamides and furosemide. Many of these can trigger bullous pemphigoid. These are the top two. Now, severe psoriasis, I guess I'm not going to talk about erythrodermic psoriasis today. I'm going to concentrate pretty much, this is going to go for acute pustular psoriasis, but there are others that we're aware of. These are just eliciting factors: irritating substances, pregnancy, withdrawal, rapid withdrawal of steroids, oral contraceptives, lithium and infections. But acute pustular psoriasis, generalized, this kind of sea or lake of pustules that can form larger bulla. These patients can be erythrodermic. They have fever and other findings that we'll talk about. Subacute pustular psoriasis, these patients are less toxic. They tend to have small blisters like you'll see here, but also drying and kind of older phase blisters that develop this collarette scale. This is also known as the Lepierre variant of pustular psoriasis. There's chronic forms of pustular psoriasis or halipo or acral, but again, this is not an emergent situation. These are more day-to-day clinics that clinical patients that come into the outpatient clinic. Now, for acute generalized pustular psoriasis, they develop, as I said, these lakes of pustules and small pustules, and they can desquamate as well. This is the pretty much classic pattern. Head and neck usually spared, but you can see it in severe cases. Palms and soles can be involved, as you can see here. Here it just says face spared on, not everybody, but on occasion that one case had it. Fever, chills, arthropathy, and tachycardia are not infrequently seen. Hypocalcemia, leukocytosis, elevated ESR, and CRP are also noted. Now, the reason why we do admit these patients and arithrodermic patients is because of high output failure, the edema that they may develop in the lower extremities. They can develop high output cardiac failure. Also, because of open wounds, etc., sepsis is a concern. So wound and blood urine cultures, chest x-ray should also be performed. This just shows the psoriasiform spongiotic dermatitis that you do see with psoriasis in general, but in the epidermis, and this doesn't really show it, but you'll see little lakes or little pools of neutrophils within. Those are spongiform pustules of Koch, which is usually subcorneal or even in the superficial papillary dermis, superficial dermis. Monroe microabscesses are usually abscesses or microabscesses loaded with, they're sterile. So it's not really a real abscess, it's a pseudo abscess, but these are just little collections of neutrophils within the cornified layer. The approach to pustular psoriasis basically is your approach that you would do for any blistering dermatosis, except for you don't provide steroids. These patients obviously will need, electrolyte balance evaluation, etc., antibiotics for secondary infection if that's a possibility, but then you have these options. And not infrequently we'll combine them. For example, etanercept takes a while for it to kick in. You can use, no steroids. You can use topical steroids, but not high potency, okay? And not generalized all over the body. As far as systemic steroids is what this is referring to, and staying away from, because you can exacerbate the situation. Now, going back to the therapy, cyclosporin's probably your best bet because of its rapid onset and therapeutic effect. You can combine cyclosporin with a biologic if needed, if the patient has a form or history of severe psoriasis. Once they you don't want to use light therapy initially. You need them to calm down a little bit, so it's not really an initial option when they present. Drugs that elicit or stimulate possibility of forming psoriasis include NSAIDs, terbinafine, ACE inhibitors, antimalarials, beta blockers, and lithium. Okay, this is PG. We do see a lot of ulcers, and as you can imagine, many patients with pyoderma gangrenosum do have underlying issues that they may be admitted for, or they're going to be admitted for. You can admit for infected and severe pyoderma gangrenosum, a little bit more difficult. But if you do get a consultation, a patient with suspected PG, after you work them up and look at everything, you do want to look. There are reasons for them to be there outside of PG, and that includes inflammatory bowel disease, rheumatoid arthritis, hematologic malignancies, including leukemia, lymphoma, polycythemia, IgA gammopathies. Additionally, liver diseases and infections such as Hep C have been associated. Connective tissue diseases like lupus, and clearly immunologic conditions like HIV, sarcoid can be associated. Other associations include hidradenitis, acne conglobata, solid tumors, and COPD. Now, this just kind of goes through the more common forms. There's 4 or 5 that we need to know, and I'm not going to get into neutrophilic dermatosis of the dorsum of the hand and all that stuff that we know that there's probably some form of variant between this and bullous sweets. However, for PG in itself, for this specific neutrophilic dermatosis, there are ulcerative variants. Not infrequently, they'll present early on with small little malignant pustules, hemorrhagic pustules. And then they'll develop deep ulcerations that can even show tendon or deeper with surrounding erythema, dusky violaceous erythema. Ulcerative forms are associated with inflammatory bowel disease and rheumatoid arthritis, as well as underlying hematologic malignancies. Now, they like we did, it can be pustular in itself, and this is an ulcerated pustule, but they may present initially as these small little pustules with a dusky erythema surrounding. Here's another one as well. These are more superficial and less likely to scar. These have been more associated with inflammatory bowel disease and gastric bypass, the whole GI tract. Bullous forms. These are superficial bulla with surrounding inflammation. Some of them will have hemorrhagic or even purpuric changes. These are violaceous undermined borders. It may affect the face, may affect upper extremities and dorsum of the hands. When they do affect the face, there's a variant. It's called pyoderma maligna that is associated with Wegener's. It's probably some form of variant of this. It's associated with leukemia, myelodysplasia, as well as inflammatory bowel disease. Vegetative forms tend to be a little bit more easier to treat, but these are, they follow trauma, and they're exophytic, may produce even sinuses. Periostomal, these tend to be associated with inflammatory bowel disease. This is an interesting picture. I'm not going to really, it's probably periostomal, but just to kind of give you an idea, you remember that this is a disease that in 30 to 40% may present with pathergy. We've seen multiple cases of patients with extensive cosmetic surgeries that have undergone or have developed, I should say, pyoderma gangrenosum at the site of the surgery. So that's always something that you want to keep an eye on. Patients admitted, they get their, whatever surgery is done, and they develop ulceration. The first thing the surgeons will come to you and say is it's infected, and maybe they don't even come to you, and they start debriding, and it gets worse, and debriding, and it gets worse. And this is not an infrequent situation, unfortunately. It's not usually the first thing people think of status post-surgery. These tend to be extremely painful. Cutaneous and mucosal involvement has been described. They heal with these cribiform scars, as you can see over here on the bottom right, or approximately about 4 or 5 o'clock on this ulcer. You may have one or many ulcers, and some of them may coalesce. We talked about this, that they can be associated with malignancy, and when they do, these tend to necrose rapidly. They may have signs of toxic symptoms. Inflammatory conditions also they're slower. They don't grow as fast. They may spontaneously regress. Also, pyoderma gangrenosum, that tends to be a little bit more refractory to therapy. You really should consider that underlying malignancy. Just some pathogenesis. It's idiopathic in the vast majority of patients, or at least half of them. Pathergy, like we said, is about 30%. It's been associated with interleukin 8 and 16. It's in the spectrum of autoimmune. However, can be associated with autoimmune disorders. There's a defect in the cell, both mediated and humoral immunity of these patients. It's a diagnosis of exclusion, so it's not really like you're going to have an answer. I mean, there are, as we talked, there's some clinical features that should raise suspicion for this entity. Now, you do need to exclude many things. You need to exclude one thing that's not on here. You need to exclude the possibility of deep fungal infections or angioinvasive lymphomas. You need to exclude the possibility of cryoglobulins and connective tissue disorders and vasculitides, as well as procoagulopathic disorders, rheumatoid arthritis. Again, underlying malignancy that's a myelodysplastic syndrome or gamopathies, underlying renal hepatic issues that the patient may have, like Hep C. Tests to consider in these patients, depending on the patient, include, colonoscopies, bone marrow biopsy in a patient high suspicion for myelodysplasias or gamopathies, hemoccult blood, for patients with GI cancer or even inflammatory bowel disease, vascular studies, radiographs, skin biopsy for H&E and immunofluorescence. Immunofluorescence will clearly help you in this case, more so for vasculitides. However, that's the only thing it'll exclude pretty much. As far as skin biopsies for H&E, this is not a definitive diagnostic study. This will help put the picture together, but it will not definitively. There are no pathognomonic findings. You'll see, these kind of rolled edge borders at the site of an ulcer with a dense sea of neutrophils underlying in the dermis. Overlying may or may not be infected, but where the game cuts changes is that we can, especially if it's a solitary lesion and maybe the patient is immunocompromised for whatever reason, we can exclude the possibility of underlying infections and even malignancies. As far as the treatment's concerned, I think pretty much initially, in most cases, okay, there's successful treatment with topical steroids and possibly antibiotics. Should culture these lesions, make sure they're not super infected because that is a problem. You can go on to intralesional or even oral steroids. We have used that in conjunction with medications like topical tacrolimus, or Protopic, as some of you know. In cases that are a little bit more recalcitrant to therapy, you should consider cyclosporin and any of the other steroid-sparing agents. This again goes into a whole other subset of therapeutic options for patients that you'd like to get off steroids if you can control them. These are others. Immunomodulators like infliximab and etanercept have been used, and dapsone, colchicine, etc. Here's topical tacrolimus. Now it says Apligraf here. Let me just see here real quick. Okay, so just to mention, Apligraf in itself is not going to do much. It'll help with healing. Once you treat the disease and you have the inflammation under control, whether that's with steroids or steroid-sparing agent, you do have the option for wound care methods, even like a VAC. I wouldn't use a VAC on an active lesion or a lesion that hasn't been controlled with immunosuppressant therapy to speed the healing. But once you do have that disease under control, the erythema is down, the inflammation's down, you can approach these wounds like any other chronic wound or subacute wound in order to treat that faster. But you do need to make sure that the inflammation and the activity of the disease is completely nullified. You do want to avoid azathioprine, GCSF, GM-CSF, and hydralazine, isotretinoin, and methotrexate. Some of these have been shown to worsen the disease. Now, vasculitis in itself, I mean, I can't really get into this too extensively because this is an hour lecture by itself, definitively. I'm going to highlight some things just to give you some background, and then this year I know we have a couple lectures on this topic, but vasculitis in itself is inflammation and necrosis of blood vessels leading to end organ damage, whether it's the skin or underlying internal organs. It can be localized or diffuse, and these can be primary or idiopathic or secondary, and this just goes into the many causes, and this is not the classification we typically use, but just to kind of give you an idea, the causes of vasculitis are extensive. So when a patient does have vasculitis and they are admitted for whatever reason, or you admit them for this reason, you do need to work them up appropriately and search for the answer. Now, younger patient, that has vasculitis and it's lower extremities and it's kind of short term and they have no symptoms or signs, it's pretty much going to be a hypersensitivity phenomenon or idiopathic, unlikely to have an underlying association. However, if these things are recurrent or resistant to therapy or generalized to the extent where it involves trunk and head and back, it becomes very diffuse. You should start considering other etiologies that's triggering the vasculitis. And these include, as we saw before, connective tissue diseases, inflammatory bowel diseases, malignancies, and even foods, hypersensitivity reaction. Now, the classic classification is large, medium, and small vessel. Some of these overlap. Giant cell arteritis and Takayasu, these are both large vessel. Polyarteritis nodosa is a medium-sized vessel-only disease. Kawasaki's is primarily medium, however, can affect small. Wegener's and Churg-Strauss, they affect small vessels as well. Microscopic polyarteritis or polyangiitis, this can affect small and medium. Hennig-Schönlein or IgA vasculitis is a small vessel vasculitis. Cryo is predominantly small, however, can affect smaller vessels. Urticarial vasculitis, small vessel vasculitis, and erythema elevatum diutinum, which is not really where we're going with this topic, as you all are aware. These patients not infrequently will have fever and weight loss, as they may have had a virus or may have had a, upper respiratory tract infection and may develop vasculitis, but vasculitis in itself, because a pro-inflammatory disease, clearly can establish itself with fever. Many of the entities that we talked about, and again, to go through each and every one is beyond the scope of this, will have associated renal, pulmonary, central nervous, or peripheral nervous system involvement, as well as GI involvement. Okay, so you do need to do a thorough evaluation of the patient. And if the patient's admitted, well, you might as well check, and especially if they seem sick. Okay. Palpable purpura is just small purpuric, dusky red papules that could coalesce into plaques. These predominantly in small vessel vasculitis that are hypersensitivity will dominate the lower extremities below the knee. Once it starts creeping up, it's whether they're dependent, it could be dependent, the patient's not been moving, kind of skews your view. But if it does start going up the upper thighs and into the trunk, you need to consider other options like IgA vasculitis, cryo, etc. This one just has ulceration and edema. Now, in deeper vessels, when you have medium-sized vessel involvement, rather than have palpable purpura, not infrequently we'll see urticaria, nodules, livido, and ulcers. This is just livido reticularis in a patient with polyarteritis nodosa. Here's some ulceration to consider in a deeper vessel involvement. PAN, again, polyarteritis nodosa, medium-sized vessel, large cribriform ulceration. Again, ulceration. And nodules in that picture. Lower extremities may become necrotic, and again, when you do see this, you need to start suspecting a medium-sized vessel. The workup, as we said, you don't need to do this in every patient, especially if this is short-term, young, healthy patient. However, in the vast majority of patients, you should exclude underlying involvement. That would include renal or abdominal findings, like in a guaiac, if they have underlying malignancy or they have underlying connective tissue disorders, arthritis included, rheumatoid arthritis, cryoglobulins, and which has their own, I'll talk about that, have their own etiologies. Now, this especially is important in patients with recurrent vasculitis. You really, when patients have recurrent vasculitis, where they start the episode, might resolve after a month, 2-3 months later, they get another episode, that's concerning. And you really should, those patients definitively should have a workup. That doesn't exclude initial patients. I'm not saying that patient has one episode, you ignore it, depends on the patient. But if they're having recurrent episodes, this is definitively your approach to work up and make sure there's nothing underlying. As far as the biopsy is concerned, you look primarily at the blood vessels, and you'll see the degeneration of blood vessels with endothelial cell swelling, leukocytoclasia, which is just basically fractionated neutrophils surrounding the blood vessel or within the blood vessel, and fibrin wall necrosis, fibrinoid deposition, and extravasated erythrocytes. Now, This is predominant lymphocytic and neutrophilic um, in most vasculitides. However, in some drug-induced or hypersensitivity LCVs, eosinophils will be a predominant feature, or there are some that are granulomatous vasculitides, like you may see in Wegener's or even Churg-Strauss. So it just depends, but the predominant leukocytoclastic vasculitis is this lymphocytic with neutrophilic infiltrate. As far as therapy is concerned, now you should look and make sure you exclude all the possibilities, find out what may be triggering this. However, along with systemic steroids, your options include many of these steroid-sparing agents or anti-inflammatory and immunomodulatory drugs, including colchicine, dapsone, pentoxifylline, leg elevation, which is more symptomatic, antihistamines, compression, azathioprine, cytoxin, methotrexate, cyclosporin, Cellcept. That's your biggest go-to drugs in this subset of patients. Cryoglobulinemia. The reason I'm bringing this in, I have no idea. I guess is a common. I mean, I could talk about so many vasculitides, but I guess this one's one of interest. These patients will present with arthralgia and synovitis. They'll have some neuropathy and foot drop that you'll also see in microscopic polyangiitis. May be associated with a malignancy, Hep B and C. In the vast majority of cases, connective tissue disorders are seen. Will have and may have renal involvement, I should say. Hypertension is not infrequently noted. This is a small and medium-sized vasculitis, vessel vasculitis, so not infrequently will be associated with livedo, acrocyanosis, Raynaud's, and gangrene. And it affects cold areas. It's another kind of affect ears or affect toes. Lower extremity ulcerations with hemorrhagic crusting and necrosis not uncommonly seen. Retiform purpura and palpable purpura, because again, you can affect both medium and small vessels. This is just immune complex mediated vasculitis, but what's important is this are the three types of cryoglobulinemia. Is type 1, which can be monoclonal IgG or IgM. These typically are associated with lymphoproliferative disorders. Type 2, IgM, and polyclonal IgG. These tend to be associated with connective tissue disorders, such as rheumatoid arthritis, but also Hep B, C, and lymphoproliferative disorders. Type 3 is polyclonal IgG and IgM or IgM and has very similar associations to type 2 cryoglobulinemia. Lab values. This can look like a vasculitis and a vasculopathy, so you can open that up to start looking at a coagulopathic workup, but that includes includes cryofibrinogens and others. If you're concerned about that, the picture is more thrombotic rather than vasculitic. But your primary workup includes cryoglobulins, complete blood count, immunoelectrophoresis for underlying lymphoproliferative or monoclonal gammopathies, Hep B, C, A, and A, Rho, La, complement, and cryofibrinogen. Now, after a while, this kind of seems, this. We don't need to get into this. Now, as far as for the cryoglobulins, the way this is done in the hospital, this is hard because if it's not done right, it gives you false positives and false negatives. So really, you need to get the blood right there. And if you have an awesome resident, they'll deal with it and take it to the lab and manage all this. But you collect 10 mils of blood in a red top tube and can't have any anticoagulant in it. Now, you incubate it for about half an hour at 37 degrees Celsius, and that can be just in a water bath, and you just centrifuge that, and then you got to get the serum is what you're looking for. The protein will be in the serum, and you deposit that here. You can see here in the test tube. Now, what you're looking for is whether it becomes turbid or not, if it's positive or negative, okay? A positive result just basically means that if once you take it out of the bath, okay, and you leave it out, it will become turbid. But if it lasts too long, okay, and it's turbid, that means it's something other than cryo, because by that point it should have warmed up. A negative test is indicated by a clear or non-turbid sample, means that there are no cryoglobulins. And here's basically a positive finding at 4 degrees Celsius. So it's put in the bath, kept cold, and you'll see here it became turbid. Okay, if you wait about 2 hours, if it clears up, then it was cryo. If it stayed, that turbidity is from another agent, not cryo. After 4 degrees Celsius, after the warm bath and all that, and you separated it, and it's still clear, it's a negative study for cryoglobulins. Skin biopsies for H&E will help pretty much. There are findings that are suggestive, however, not definitively diagnostic of cryoglobulinemia. You will see vasculitis, superficial and deep, and some thrombosis. And this just shows thrombi, degenerated blood vessels. But overlying, you also see this epidermal necrosis, and these are the ulcerations that develop in these subset of patients. Your treatment options, obviously, find out what's going on underneath, whether it's rheumatoid arthritis or if the patient has Hep C. You do need to avoid cold. We don't have stanozolol anymore. It's been discontinued. Interferon A and ribavirin for Hep C. Now, if you use it right away, this can make it worse. So you do need, sometimes they add steroids. Systemic steroids plus cytotoxic agent in some patients, some subset of patients. Obviously, cyclosporin wouldn't be an option in a patient with an underlying lymphoproliferative disorder. However, methotrexate might be an option. NSAIDs treat the underlying issue, not just malignancy. Plasmapheresis is the option, is an option. DIC, okay, or purpura fulminans. These patients have a history of illness. They usually tend to be sick. The infection, neoplasm, chemotherapy, pregnancy, hepatic failure, transfusion, burns, fat emboli, whatever it might be. They could be in the hospital and develop a procoagulopathic state. These patients will have hemorrhage at the venipuncture site wherever they get punctured or incised. Could you please put mute on whoever jumped on? Might still be here. I'll put you on mute. Thank you. And they will develop ecchymoses, purpura, and petechiae. They may develop some palpable purpura, but predominantly these are purpuric lesions that it can be macular or even bulla. Not infrequently, you'll see gangrene in patients with DIC and necrotic ulcers as well as a result of thromboembolic events into small, medium-sized vessels involved in the skin. Hemorrhagic bulla, differential, and this is vast. However, DIC is a common entity we see in the hospital. Not common, but we do see it. Basically, there's an overstimulation of the intrinsic and extrinsic coagulation pathways, and there's fibrin release, which basically leads to thrombosis and necrosis. This fibrin traps the platelets and leads to more hemorrhage. It's consumption, consumes platelets. Lab values, PT, PTT, CBC, fibrinogen, this FDP, the D-dimers, protein CNS, and antithrombin 3 proteins. Now, this just kind of helps you to see, how active they are, and if it does fit that picture as it's diagnostic. I mean, not definitively diagnostic, however, it helps in the assessment of the patient as well as diagnosis. Cultures and skin biopsies should be performed. Obviously, cultures and skin biopsies to exclude vasculitis and to exclude infections like generalized systemic fungal infections in immunocompromised patients. The biopsy is thromboembolic, okay? So congestion of all the blood vessels from top to bottom. You'll see some collagen degeneration and necrosis of the epidermis. This, I can't really tell, but it looks like it because you'll see the epidermis here kind of has that purple hue. Here it became completely pink or eosinophilic. So we do see ulceration, not infrequent, and extravasation of erythrocytes here, which gives you the purpura. The treatment, these patients, not a great prognosis. If the patient does have sepsis, antibiotics, if there are protein C deficiencies, protein C concentrates, heparin, then Coumadin to stop the thrombotic event, the coagulopathy, supportive care, and frozen plasma, platelets. Neck fash, you can use steroids. DIC, I didn't mention that, but you can. It's like you can use steroids. Some, they show that steroids, depending on the stage, has been successfully used in many patients, especially when they're crashing and in shock. But that's a whole separate issue in itself when they are in shock. Necrotizing fash. This is basically a disease of the fascia, an infection with secondary hyperinflammation. So you have not only an infection, microbial instigator, you have hyperinfection. There's necrosis of subcutaneous tissues, and this moves along fascial planes. The three most important causes initially was thought that they were group A strep many years ago, but what we're finding now that the predominant is, even though that may trigger it, the predominant microorganisms are, it's a polymicrobial disease. Clostridium has also been implicated. Oh, here's that thing we were just talking about. This strep is number one. However, now we're seeing this more polymicrobial. Not infrequently, we'll see these two, strep and staph, work together. But then again, this becomes more polymicrobial over time, both aerobic and anaerobic pathogens. It has multiple names. Fournier's gangrene is a neck fash of the perineal area involving the scrotum in men. These patients not infrequently have chemotherapy, steroids, long-term antibiotics, or immunosuppressant therapy, are susceptible to infections of the fascia, which I've seen. A patient with bullous pemphigoid, older woman on immunosuppressant therapy, and developed neck fash and unfortunately passed away. These patients also can have associated underlying cardiac issues. Diabetes mellitus not infrequently has been associated with neck fash or trigger, somewhat immunocompromised. The trauma obviously is needed to elicit or expose the fascia to microbials. This can be for many different reasons, as you can see here. Patients may have renal failure, and obviously immunosuppressive states lead to higher incidence of neck fash. Dermatologic conditions, whether they're primarily the cause or because they're on immunosuppression, have been associated with neck fash. I told you about the patient with bullous pemphigoid that was on mycophenolate mofetil who developed neck fash. Actually, she had linear IgA, I'm sorry. And then she was not drug-induced, and she was on Cellcept and developed it. Fortunately, she passed away. But GI associations, diverticulitis, perirectal abscesses, perforated viscus, malnutrition, obesity, pregnancy, advanced age. Clearly, these can alter immune status. There are three variants, and basically you can look at it based on chronology of this disease. If it's fulminant, happens within hours. If it's acute, days, and subacute, weeks. If it's on the trunk, tends to have a higher association with mortality, tends to be a little bit more vast and limited as a result. These are severely painful, and not infrequently, it might not look that bad, but they're in excessive pain. Crepitus is not infrequently noted. Fever, chills, constitutional symptoms, shock, neuralgia, even over time, anesthesia. Okay, so they may lose the pain. Tachycardia, tachypnea, weakness, shock, just mentioned this. Venous thrombosis association. Bacteria, as we know, invade through the fascial planes and release. It's a hyperimmune state. You have the exotoxins and proteins, etc., so on and so forth, super antigens. The bacteria themselves all eliciting not only the attack by the microorganism, but also a hyperimmune response to those bacteria. Here it talks about the strep superantigen and the activation of T cells, which can lead into subsequent issues, including shock. NSAIDs decrease granulocyte adhesion and phagocytosis, thus increased production of cytokines. It's always something to keep in mind in the subset of patient. This just shows there's type 1 anaerobes, Clostridium, E. coli, Vibrio associated, type 2 group A strep, and staph. These patients, depending on their state, I think for the diagnosis, you need a biopsy and a CT scan. That's the bottom, and a fasciotomy. That's basically it. Deep biopsy and a fasciotomy. But just to kind of check their overall state, you want to check their blood gas levels, bicarb aldolase, because many of these patients may enter into DIC and shock, sed rate, calcium. So this is just basically that approach, just to evaluate the patient's system. Here it goes, CT scans and MRI. I should say MRI is the gold standard, and fasciotomy with culture. Gram stains, just talking about blood tissue and wound culture should be done. The skin biopsy, I mean, you really need a fascial or muscle biopsy. You should see necrosis as well as polymicrobial findings with gram stains. You find organisms, a lot of neutrophilic degeneration and abscess formation. Here we talk about treatment, and the fasciotomy and surgical debridement is number one. Added intravenous antibiotics, Clinda or Metron with penicillin, and third generation cephalosporin. Supportive care in the ICU depending on their states, and many of these patients are amenable to therapy with concomitant steroids, not alone with steroids. Once you have this infection under control, and they have the ulceration, you do have the typical wound healing options like hyperbaric oxygen, grafting, VAC. IVIG is more of a keep the immune system in check and under control when it is in hyperimmune state. Okay. So that's an hour. And I think the next couple, this just talks about AGEP, which is a drug-induced pustular dermatosis. The more common causes include penicillin, cephalosporin. This presents clinically much like pustular psoriasis. However, will have facial involvement, even intertriginous areas. They will have some blood findings like leukocytosis, some eosinophilia. LFTs typically tend to be normal, and hypocalcemia can be seen. But they will have a drug history. So it starts acutely and it has a drug history. Histological findings, it's a subcorneal pustular dermatosis with slight psoriasiform hyperplasia. Very difficult to distinguish this from pustular psoriasis. However, again, you do have the medications that have been associated. There's some subtle findings that they noted, differentiating histologically AGEP from psoriasiform pustular dermatoses, but that's beyond the scope of this talk here. The therapy, you just withdraw the agent, biopsy the patient, make sure topical steroids and antipyretics. And I think we're going to stop here because we're going to be going in. I think I cover staph scalded skin. Let me see here. Heparin-induced necrosis, which basically we do see. This basically, you have the platelet activation as a result of heparin infusions. Basically heparin binds to platelet factor 4 tetramers. This basically releases the platelets, allowing them to form a procoagulopathic pathway and thrombin generation. So they become thrombotic. The vast majority of these patients develop 5 to 14 days after starting heparin. Okay. 30% will develop a little earlier, and very rare they'll develop later on after 3 weeks. Okay. It's a skin necrosis. You can biopsy. The biopsy won't be definitive as far as it'll just show coagulopathic event, thromboembolisms and stuff, little small thromboemboli. But what you will see is you have the history of the heparin given to the patient. You'll have consumption of platelets And if you have anti-heparin platelet factor 4 antibodies, you can detect that. The therapy is heparin cessation, and then use non-heparin anticoagulants. They could be either the direct thrombin inhibitors or factor 10A inhibitors. You can also use vitamin K antagonists. Okay. Sorry I went so fast because I just don't like to go over an hour on these lectures. This is late. Everyone's here, and want to make sure. I will send you the PowerPoint. Well, not the PowerPoint, but rather the PDF